Let's make a start then.
Okay.
Hi, everyone. My name is Saurav Jain. My pronouns are he and him, and I'm one of the team members here at CERSH, that is Center for Excellence in Rural Sexual Health. I work and live in Bendigo, and it is my pleasure to welcome you all to the CERSH's 2022 Sexual Wellness Professional Development Webinar Series, which is currently being held monthly for the rest of the year. Before we begin, I would like to do a quick acknowledgement. So on behalf of CERSH, I would like to acknowledge the Jaja Wurrung people on whose land I am based on today and speaking to you from. I also acknowledge the traditional custodians of the land on which each of you are joining or working from today. We extend this respect to elders past, present, and to all the Aboriginal and Torres Strait Islander colleagues joining us today. It would be wonderful if you could introduce yourself and acknowledge the country that you're joining from in the chat. Before I hand over to Siobhan, one quick note about housekeeping. There will be time for Q&As at the end of the presentation. Please use the Q&A function to drop your questions as they occur to you through the presentation, and I will do my best to consolidate those and pose them to Siobhan at the end of the presentation. And without any further ado, over to you, Siobhan.
Thank you. I would also like to acknowledge the land on which I'm coming from, which is the Wurundjeri land. I will share my screen. And let me know, Rob, if that's okay. Is that working? Okay. So welcome everybody to one of the wellness sessions that CERSH is running. So as you can see, I'm Dr. Siobhan Bourke. I'm a senior lecturer and I work for CERSH, and I also work in the Department of Medical Education as the Director of the Sensitive Physical Examination. So I'm just going to talk to you a bit about the other job that I do. So in the Department of Medical Education, I run the Sensitive Physical Examination, which is quite an extraordinary program within the medical school, where we teach the medical students. The level of medical students are year 2, and we teach them 3 different tutorials. So I'll explain all of that to you, and just as way of some of the practical tools that we use, obviously here's a speculum and here's an orchidometer testing this is all, you can compare these to different size testicles to the actual volume of the testicle to see if they're within the normal range. So the Sensitive Physical Examination program started in year 2000, and it was originally placed in the Department of General Practice and set up by a general practitioner. It was modelled on some of the programs that have been run in various places around the world. America or the United States is one of the places where they do run a fair bit of these programs, but a lot of the programs that you look at in America are run by organisations who they're sort of outsourced from the universities that pay for their services. So they sort of run as a little mini business. And they run a little bit differently to ours. It was originally funded by PAP Screen Victoria, because it has been, my previous job was at Victorian Cytology Service, so I knew this quite well. It has been noted for years that medical practitioners are not as good at taking PAP tests as nurses, and the nursing training to become a PAP test provider is far more extensive than anything that medical students were ever taught during their medicine, or even as they were training to be general practitioners. So PAP Screen Victoria funded the startup of this service to try and improve the examination and taking PAP tests. We've moved a little bit away from that model to include other things, and as I go through, I'll show you just the different types of examinations and things that have been included, and why we've sort of moved a little bit away from cervical screening. The difference between medical people and nurses was noted in taking pap tests was noted by the lack of an endocervical component in, or less often medical practitioners were finding an endocervical component, which sort of led to belief that maybe they weren't really finding the cervix and placing the brushes in the eyes of the cervix, so therefore not taking as good a pap test as the nurses seem to be doing. So there needed to be some sort of improvement on how pap tests were taken. So the program later on moved into, after several years of being in the Department of General Practice, moved into the Department of Medical Education. And at that point, the second tutorial was added, which was the breast examination. Our third tutorial is a male genital and digital rectal examination, which was added in 2009. She's trying to, there we go. So we have around about 35 different clinical teaching associates. So the idea of this program is that the students actually get to learn the examination on a patient who is in a way a professional patient, but the difference in these tutorials is that there is no clinician in the room. So the clinical teaching associates are acting as the teacher and the patient. So they can give direct feedback to the person who's examining because they're experts in the examinations that they teach. They're not experts in the medicine, but they're experts in the actual examination, the examination technique. And we particularly concentrate on consent and communication during the examination. Most of the students are really nervous about performing the actual examination, but the main thing, and the thing that is a thread throughout the 3 different tutorials, is the consent and communication skills that they will develop. There are always 2 CTAs in a room at a time, or more, depending on what we're doing. But during the examination process, there's always 2 CTAs, one acting as the patient and the other acting as what we call a buddy, which is really there for the safety of the CTA and the student, and can also help guide the student. It means that there's sort of an observing pair of eyes, as well as the patient who's can give feedback from a patient perspective, as opposed to just a clinician or an observer's perspective, which is really how they learn every other form of examination. So as you can see, when someone is actually performing an examination and they are given 15 minutes to do the whole breast examination, including the consent and the examination, they're giving 35 minutes to give to do the gynae examination, and they're given about 30 minutes to do the male examination. So during that time, we have 1 student and 2 tutors. So we are probably the most labour-intensive tute, and therefore probably one of the most expensive tutorial in the whole of the medical school, definitely, but probably the whole of the university, because there's rarely 1 student to 2 tutors anywhere else. So what we perform in each of the tutorials is, in the gynae, they get to do they do a sort of rudimentary vulval inspection at the moment. When I came into the program about 3 or 4 years ago, the expression used to be, as soon as the woman has raised her gown, it's good to get straight on to do the speculum examination, because no one wants any people looking at their genitals for too long. And I've kind of changed that, in that, well, we need to actually add in vulval inspection, because if you are going to undress and be examined in the genitals, this is a great time to do it, and it really takes only a couple of minutes. So we've introduced the idea of this is when the vulval inspection would occur. Then they do a speculum examination and they try and find the cervix. That is not the, ultimate outcome of this. Really, it's just to experience doing a speculum examination mostly for the first time. Then they do a bimanual examination of the vagina. So they learn those two techniques. They will fully consent, and consent is something that is real and so therefore can be withdrawn. And I'll talk about the 5 stages of consent in a little bit. The breast examination, we actually do the breast examination first because it's probably the least confronting for the students, and then they've met the CTAs and sort of understand the dynamics of the tutorial. So they do an inspection of the breast, palpation of the breast, and palpation of the lymph nodes. The male examination includes inguinal hernia examination, male genital examination, so they're finding the testes, the spermatic cord, the epididymis and the penis, and then they do a digital rectal examination, inspecting the perianal area, and then also doing the DRE and most likely, hopefully, finding the prostate. So that's the idea for the male examination. But we do acknowledge the fact that everybody has a bottom and an anus, and so therefore digital rectal examinations are performed on both male and female. Now, when I started in 2018, I did want to address the sort of gendered language and gendered learning. So we do talk about teaching them anatomical or biological female anatomy and male anatomy. We have done some professional development for the CTA so that we're trying to get away from being totally binary, even though we do need to teach in this first instance biological female and male anatomy. So the other thing that I also did was change the male CTAs used to be called the urological CTAs, and that just sort of annoyed me because everybody's got a urological system, but it came from the fact that the most DREs are performed for prostate examination, and so therefore they're mainly done in the specialist area by urologists. So that's why their name was typically, or traditionally, the UTAs, but now they've become the male CTAs. We've also introduced name badges. So I've got mine here with our pronouns on and what the role is that we perform. The CTAs had the choice of A, getting a name badge, B, what name they put on it. So sometimes the CTAs don't always use their usual name. And they also had the choice of whether to put pronouns on it or not. And most of them did choose to put their pronouns on. So that was great. One of the other things that I did was I sort of assessed the program for the first year, and then having gone to a lecture or workshop on flipping the classroom, I decided that it was a good idea if we could flip the classroom. So really what flipping the classroom is meaning that all the practical, the learnings that you can actually get from being in the presence of your tutor, you do that with the tutor, and all the other theoretical learning you do prior. So we did have some of the videos and things set up. So we just developed more videos. So we have videos for every one of the tutorials. And then when they sent those videos, they need to have watched it. It's a prerequisite of coming to the class so that they're prepared. And then instead of having an introduction where they would sit down and the CTAs would talk them through the entire examination, what we decided to do was to have them already see the examination, read the information, and then when they came in, they would do practical tips. So for instance, in the breast examination, the first practical tip they learn is to do the palpation technique, which is a flat-handed circular motion technique on the breast, but they learn to do it on their forearm. And the CTAs that are doing the introduction and practical tips session go round and talk to them. So they start interacting with the CTAs. They start touching them just on the forearm, and so we sort of develop things like that. So we've got the practical tips, which I'll talk a little bit more about later. And then we've got the videos and the documents, and they have to have done all of that before they enter the tutorial space. And I'd have to say that, you know, the record of you might get 1 or 2 people for the entire cohort who don't watch the videos beforehand. We have noted also that this sort of seems to reduce the anxiety level that the students have, because seriously, when I first did it, they used to all walk in and they were like rabbits in the headlights and so nervous, and then now just sort of getting straight into it without having to you know, sit through a relatively didactic lecture, they're able to, you know, get into it and start moving on through their tutorial, and they seem to be a bit more relaxed. And I'll show you some stats about their anxiety levels a bit later. We do also have evaluations. We've got years and years of evaluations, and when I came in they were doing it all on paper, and someone had to manually put in all the data. And so I just spoke to the evaluation team in the Department of Medical Education and said, are you able to do this online? And they're like, yes. And so they were so thrilled to be able to do that, and that has made the world of difference. We can get data immediately back on any of the tutorials. We've also made it one of the other things was that they use the evaluation tools in a way that they could identify students. And now I'm like, no, we need to properly identify students. So all of the students who work with particular CTAs are documented, and therefore all their evaluations are completely and utterly anonymous. So that's been a good kind of delineation between those two things for me. It also means that we can address some of the students' needs. One of our jobs really is to identify students who are struggling, and often we're a bit of a canary in the gold mine. If they're struggling with us, it sometimes is an opportunity to address other things that are going on. So we do, we're not marking them, there's no assessment, there's no grade, but if someone is particularly nervous, they can't get through the tutorial, anything like that, or they're just rude and arrogant, or they don't get what we're trying to do, we report that back to their clinical school, and therefore they can sort of address those things before it goes too far. When the CTAs enter the program, the other thing that I've introduced is actually a sexual health physician, not myself, but someone external to the university does examine all the clinical tutors, so that we, you know that their anatomy is completely within normal limits. So as I was saying a bit before, I've gone over this a little bit. They do the pre-reading and the videos, and the videos cover consent, communication techniques, and then also the examination. We were lucky that all of that work was completed before the pandemic, and I'll show you why. So when they're in the tutorial space, they do the introduction and the practical tips, which I spoke a bit about before, and I'll show you some of those things that we do. They have a demonstration, so a group of students will go in with 2 of the CTAs. One of the CTAs acts as the doctor, or what role the students are then going to take, and one of the CTAs is the patient. Then they split into smaller groups, and each student gets to play the role of the doctor. One of the CTAs is the patient, one is the buddy, as I said before. Then at the end of that, the patient gives the student feedback directly, and then the observer does as well. And we also talk to them about the fact that they're often, with the gynae exam, there's often 2 students in the room. And so what we will say is, you know, it's often harder for the first student. So just so that you can kind of balance that up, because the second student will have seen the videos, the demonstration, their colleague, and then they get to go. So it can sometimes make it a bit easier, but not always. And then we get them to fill in surveys. We get them to fill in one before the gynae tute and the male tute, and then we get them to fill out one afterwards. With the breast tutorial, it's the first one. There's a lot going on for them. So we just actually do a post-tutorial survey. And so examples of some of the practical tips. So the first one I was showing you before was the palpation technique. So we get the students to practice on their own forearms and then the CTAs. And basically we're getting them to have a flat hand. So the first thing they do is this. And so we're always like, relax your knuckles. You want to do it with the flat part of your fingers. If you examine a breast like this, everybody's breast will be lumpy. So flat part of the hand, and then we get them to palpate. And what we're doing with our palpations in a circular motion is one light for superficial levels and a deep one for the deeper tissue. And then they sort of drag it along and move around. And they do that right over the whole chest, but we get them to practice that on their arms so that they can feel the difference between the light and the deep and the drag. One of the most common things is no one wants to hurt anybody. So one of the common things is that they are doing their light really light and not feeling anything, and their, you know, deeper one is only just light. So we sort of getting them used to the kind of depth and the that they can actually palpate somebody's breast with. But it's also just an introduction to them meeting some of the CTAs and, you know, touching themselves, touching the CTAs on the forearm and stuff in a safe kind of place. With the gynae examination, the main thing is, and I'm sorry I don't have a speculum with me today because I'm at home, but with the gynae examination, we get out all the speculums and basically put a different type of speculum in front of all the students and say, right, let's pick them up, and this is how the ratchet one moves, and this is how the metal ones work, and so we go through all of those. We've experimented with a few other things. The frontal, but these were our knitted vulvas that we got someone to do because we were talking about how to separate the labia. But in COVID times, this became inappropriate from a health and safety point of view, and also the CTAs didn't sort of thought they looked a bit non-professional, so we've given up on that. The men have decided, so I did all of this kind of work with the actual CTAs to work out what they would like to do best. The men have decided that the trickiest part is examining the testicle. So what we do, we don't use real eggs. I am at home. We've bought a whole lot of just plastic eggs. We put them inside just a normal glove, normal disposable gloves, and we're trying to use all the ones that have gone out of date. And so we can get the, you know, testicle to basically hang in the glove, and then we teach the students how to hold the testicle and examine like that. And if you've got an egg, particularly if you've got a real one, you don't want to crunch it too much, you don't want to break it, but it gives them an opportunity to examine the testicle and show how they're doing it before they're actually holding a real testicle. And we did have another idea we haven't quite worked out, but how to get the spermatic cord into here so that they could sort of run their fingers over that. So that's sort of just the practical but funny little things, and they get them to get up and down and move, and in the various ways that they would get them to do within the examination, and that's worked really well. So the students seem to be a little bit more relaxed by the time they're going in to see the demonstration. So the most important part of our tutorial is consent. So we are really you know, we really drive this message home, and we always talk about our 5 steps of consent. So explain the examination, ask if there's got any questions, ask about understanding. With the understanding, we've started doing a teach back type of method, because if you say to someone, do you understand, the most common thing is yes, because they just want to agree. So what we do is say, just so that I can check your understanding, can you explain to me what we're about to do in the examination? And so the examples the CTAs will give is like, the breast examinations in 3 parts. You're going to do an inspection with me moving my arms, and then you're going to examine my breasts, and then the 3rd part is examining the lymph nodes up here and under my armpit. And they make it as simple as that. And then if the person does understand, so you've checked their understanding, you arrange a stop signal. And what we try and get them to do is not, you can stop for whatever reason. Don't give the patient a reason. Just say, if you want to stop at any time during this examination, you're in control. Just give me some sort of stop signal. Do you want that to be the word, or you put your hand up, whatever you need. And then the consent process is a verbal, are you willing to proceed? We've sort of stuck on the are you willing to proceed over are you happy, or do you want to go ahead or something, just trying to make it as clear and concise as possible. And a verbal consent is enough. We don't have to get a written consent. So we had set up these videos, and the videos do the introduction and communication tips, and they go through consent, and then we show you the examination. So I thought I would just attempt now to show you a little bit of one of the CTAs explaining the breast examination, obtaining consent, just so that you could see what it's about. The video goes for about 4 minutes. If, you know, I can cut it short if it seems like it's going on a bit too much. So hang on, I've got to stop sharing this screen and share the other one with you. Hang on. Oh, I've lost it. Okay. Sorry, rudimentary skills here. Okay, someone's going to have to tell me whether they can see that.
Yep, it's all good.
Okay. I've got to share my sound. That's already ticked. Okay.
My name's Charlotte, and today I'll be demonstrating a breast examination. I'll be playing the part of the doctor, and Jules will be playing my patient today. So as a role play, this will be a little bit false. It's going to be abridged because ordinarily Jules would be seated at the desk with me and I would be taking a history. She would be fully dressed before we actually move to the bed to complete the examination. But for convenience today, Jules will already be changed into the gown and ready to go as I begin the demonstration. I'll be paying attention to a number of things today. In terms of my language, I'm going to be keeping things very positive because for the purposes of this demonstration, Jules doesn't have any signs or symptoms, so I'm checking that things are healthy and normal. I'll also be using quite clinical and neutral language, words like check, examine, palpate, and inspect. That's because in other exams and in other contexts, other words might be perfectly appropriate, but in a sensitive exam like this, they might have connotations which make them less appropriate. And I'll also be very aware of the power imbalance between practitioner and patient. So I'll be aware of empowering my patient wherever possible. She'll be in control of raising and lowering the gown, and she'll be covered as often as possible and only uncovered when absolutely necessary. I'll be thinking about my body language as well. As I tend to talk with my hands a lot, I don't want to be doing anything that's going to make my patient feel uncomfortable. So I'll only use my hands to demonstrate when it's useful for the patient. Otherwise, I'll be keeping them out of the way. And in terms of positioning, I'll be choosing that carefully too. I don't want to stand directly in front of my patient. She may feel like she needs to make eye contact with me, which may not be a comfortable thing for her at this point in the exam. So instead, I'll be off to the side and about an arm's distance away, which tends to be quite a comfortable distance from patient to doctor. I won't be in the patient's space, making her feel uncomfortable, but I also don't want to be too far away where it might appear as though I'm not interested or nervous of what's about.
So some of the things that Charlotte's talking about at the moment are some of the things that are really sort of obvious and practical, but some of the students get this not wrong, but they just sort of, you know, they start talking with their hands and do all sorts of things because they're concerned, you know, they're not thinking at the time, they're really nervous. So this demonstration of, you know, holding your hands together and things has been really, really useful, particularly when they go back and watch it after it's been pointed out to them.
About to happen. So having said all that, we can move into the demonstration. Hi Jules, my name's Charlotte. I'm one of the doctors working here at the clinic.
Hi Charlotte.
I believe you've come in for a breast check today.
Yes, I have.
Okay. Have you had a breast exam before?
No, afraid not.
Oh, well, good on you for coming in and being proactive about your health.
Thanks.
I'll explain how we do things here, just so you're clear about what's going to happen today.
Okay.
So the breast check here is done in 3 parts, and for each of those parts, I'll ask you to be undressed from the waist up, and you'll have a gown to cover yourself. We'll keep you covered whenever you don't need to be uncovered. The first part is a visual check, and for that you'll be sitting up, and I'll ask you to copy some simple arm movements that I'm going to be doing. You'll have the gown just down to your waist there, and that's so I can see the way the breast tissue moves against the chest wall.
Okay.
The second part is the physical check. You'll be lying down for that, and you'll just uncover on one side at a time, and I'll be using my hand to perform circular palpations of varying pressure, and that will happen in a stripe motion, covering all of the breast tissue like this.
Right.
So it might be more than what you're expecting. The breast tissue would extend from the t-shirt seam line on one side all the way to the other side.
Right.
And underneath the bra line up to the collarbone. So we'll cover all of that tissue to be thorough. The third part is a glands check, and for that you'll be sitting up, and I'll check the glands behind your collarbone and in your armpit.
Okay.
And that's because the breast tissue drains to those areas. So to be thorough, we want to check the glands as well.
Okay.
Now, you're in complete control today, Jules, so if at any point you want to stop for any reason, please just let me know. We can take a break.
Thanks.
And if
Good
you'd like to
know.
reschedule to another day, you're welcome to.
Thanks.
Have you understood everything I've explained?
Yes.
Have you got any questions you'd like to ask?
No.
Okay, are you willing to go ahead today?
Yes.
Great. So that's informed consent there. I've explained the procedure to Jules in reasonable detail. She has a clear stop signal. At any time, for any reason, she's able to stop the exam. I've checked that she's understood, given Jules the opportunity to ask questions, and finally I've had a verbal yes that Jules is okay to go ahead with the exam. So I'm confident now that we're ready to go on to the next part of the exam.
So I'll stop sharing and go back to my PowerPoint. So you can see from that video that it's quite thorough. The one thing that we've introduced, as I said before, post making all the videos is our teach back method. So that wasn't covered in that video, and we are sort of going through the process of updating our videos at the moment, yeah, just trying to change them a little bit to align with the changes, but there's a lot going on at the moment, so we haven't quite got to those videos. But you can see that they're very thorough and giving the students a best practice technique, which is one of the things we really aim to do. So if you have a look at these graphs, you can see these are the evaluations for the breast tutorials earlier this year, and you can sort of see that it's improved my technical skills. But this one I really like is it improved my confidence in performing a breast examination. You can see that these red lines really emphasise how much. We do these for about 360 students. That's the normal cohort for University of Melbourne Medical School. And so it's quite a lot of work, and we get a really good number of evaluations back. Help develop my communication skills, and we've got this one, help me develop my history taking skills, because in this cohort I was giving them a history, sexual health history taking session. So if we have a look at the actual stats, we've got the people who agree or strongly agree improve their confidence by 97%. There was a study done for through this program before I was here to ask the students who'd done the tutorials in MD2 and then how many continued to feel that confidence all the way through their medical degree and out into when they were practicing as a doctor, and that confidence didn't drop right down. It dropped a little bit, but it really remained relatively high, so that we have some stats that show us that this program does last even though they start doing it in MD2. So for the male tutorials, we've got the post tutorial survey, and it's one of the things that I feel embarrassed about performing, and this is afterwards, and you can see that drops right down, that they're not worried. I feel anxious about performing, and this also too drops down. The pre-tutorial things that sort of almost like this graph is kind of flipped over. And you can see that, I have confidence in performing these examinations is really quite high after they've done the tutorial. So then just quickly to go over the what happened in the pandemic, we were very fortunate that we had all the videos and things already set up. So we had our pre-reading and videos that we could do, and then what we did online was the practical tips and introduction, so that when the students got back from being all online and we got back to campus, we then ran catch-up tutorials. They were in MD3 by that stage. So last year was very busy, and we got through most of the MD3s and most of the MD2s that were in that year, so we basically caught up. And what we did was, when we did see the MD3s, we ran a sort of a tutorial that went straight into see the demonstration, do your examination. We dropped the practical tip stuff because they'd already done that online, and it just ensured that there was some continuity of the program, so that the second year medical students were getting something of what they should have been getting if they were on campus. It also kept the CTAs engaged, and so sort of keeping our program in their minds so that they weren't sort of losing some of their skills that they've developed over the years, and it just improved the students' readiness to take on the next the examinations when they got into MD3. So comparison to the pre and post tutorial confidence in 2018. So this shows how the students are less confident, and as they go through the tutorial, they become more and more confident. So that's a good demonstration of what the program does. And the students' response to practical tips and consent session for the online. And so we did get a good response to actually being engaged with the program during, on the online sessions, even though they couldn't then do they couldn't go straight into doing the examination stuff. But when they did do the face-to-face, they really were happy with the hybrid, this hybrid delivery support of my learning. So at least they knew that they'd got something while we were all in lockdown, and then they could go on and confidently perform. So we didn't seem to lose anything by splitting the tutorial into an online component and then the practical component. we did have some students sort of respond to the fact that it was just too long between the 2 points, so it wasn't as optimal as if they could go straight from practical tips to the face-to-face tutorial. So we can sort of use the online tutorial format for developing communication and preparation and to build confidence. And it was successful in keeping everybody engaged in the tutorial process. But we still feel that having it, you know, one after the other is a much easier way to do it. And this was what I was talking about before, this little bit of research that was done in 2016 that shows how competence, communication skills and technical skills were maintained through the medical course. So I think that's, you know, that's a really good show that the program works and it has a long-term sort of sustainability. And that was all I was going to say, but I could talk about this program for hours. So, yes, I won't though. Keep us all here. All right, I'll stop sharing, hey?
Catherine has asked if recording of this would be available. So I'm just going to tell everyone that there will be a video on our YouTube channel. I will post the link of our channel in the chat. You can check out the CERSH YouTube page. We have videos from our PD sessions, from some of our other sessions, which we do in the sexual health space. And thank you, Siobhan. That sounds like an initiative which is worth getting behind. I wish I had that in my medicine degree, because the first time I was made to examine a breast was on an actual patient. And I'm like, how do I go from my book skills to an actual patient?
Yeah, and it's actually, even though we're very expensive, we're extremely well evaluated, as you can see by the students, but even though we're very expensive, you talk to any doctor of, you know, my age or anyone who missed out on this program, and everyone's like, yeah, spend the money, because it is a really daunting thing to do for the first time, and to be able to do it on someone that you know understands your nerves, but understands what they're trying to teach you. So it's really good. Unfortunately, I can't share the videos that we've made of the actual examinations and things, because they're you know, they're university owned, but then they're also protected from for the purposes of just for education. We don't want to just sort of put them out there, but we do have, if there are programs where we, so we go to other universities. That's one of the other things I forgot to say, is that we're the only one who runs a program like this in Victoria. And we do also go to Monash and Deakin to do some of the tutorials, not all of them, which I find a pity, but we do also work with physios. We've worked with breast reconstruction surgeons. So there is an ability to have access to some of our videos and our tutorials if people want it. Obviously there's some sort of charge that goes attached to that, and we password protect any of the videos, and that's only open for a short period of time, so the students in external universities can get access to them. Does that make sense?
Yeah.
Yep.
If I were to ask a question, what would you say is the biggest challenge for a medical student to learning the examination process? Like, what do you reckon would be the biggest challenge for a person who's straight out of biomed or Bachelor of Science degree and is, I don't know, in their own cloud altogether, and they're trying to learn this?
I think the biggest challenge is, again, the students will say to you at the beginning that it's the technique, but the biggest challenge is them talking to someone. And so that's why we go over so much of that stuff that Charlotte was talking about. You have no idea. Students will stand there and they'll get someone to, you know, okay, so when you're ready, drop your gown, and this is during your breast examination, and they'll go, perfect. They don't even know that they're doing it. And so it's all those sorts of things that that the students get told. They'll get told by the CTAs, you said perfect 15 times during that examination or that chat. And they don't, they're like, oh my God. And so it's those sorts of things, that it's the interaction and the communication that really is the thing that makes someone feel awkward, and therefore making the patient feel awkward, so that you kind of, so if you can get them to be able to consent and go through a process that this is all normal, then the examination techniques are actually not that difficult. So they would probably say to you it's about the technique, but really it's about interacting with the patient as a human and on the same level.
Yeah.
So yeah, I mean, from our perspective, that's what we think is the most important. If you ask the students, they'd say, so I don't know how to handle the speculum. But, the good thing is that they're given speculums to sort of, play with, for want of a better word, beforehand. And the CTAs, the buddy CTAs, watch them like a hawk. And so, they can really help them if they're having trouble. But normally by the time they've got through that process, they're actually more relaxed than they realise. So that they rarely do you get someone coming at the CTAs with a shaky hand holding a speculum. That's actually relatively rare. Yeah. But it's funny, some of the things that they do without really, it's the same. I don't know whether you've ever, I mean, people will look at this video, my hands are going all over the place. And so, that sort of thing is you get, oh, look at that. And so if I hold my hands together, I know that they're not flapping about. Yeah.
Space fillers and these gaps in between conversations seems to be a challenge.
Yeah, that's exactly right. It's all those little filler words, and we call them filler words, that people use, that students don't realise that they're using. And then if they've got the wrong filler word, like, and they do this, amazing. Perfect. You've got perfect breasts like that. And some of the CTAs will go, thank you. Like this. The students will be like, oh my God. So,
and I'm guessing there would be a lot of strategies that would be given out by the CTAs to address these.
Yes.
Yeah.
So one of the things that the CTAs are excellent at is the feedback. Mm-hmm. So, that's one of the other things that we practice and we get professional development on. Yeah.
Bit of a tough question. Is there anything done differently for people coming from culturally and linguistically diverse communities, or people coming from different faiths who might not have the same understanding about genital examination or breast examination for that matter?
Is that a question from the perspective of the medical student or the perspective of the patient?
A little bit of both. Let's say a person comes because of the examination, but because they haven't ever gotten an examination done in the past, and their idea or their idiosyncrasies might be different from a person who's habitual of examining people who are aware of these examinations.
Yeah, so some of the techniques, and once again I'll go back to communication and consent, and so we're trying to teach people appropriate language, and one of the things I get picked up on all the time by the CTAs is I say feel instead of examine, and so it's about language. The thing I talk to the students about, and as you know, Rob, that we have the sexual health discovery subject for the MD students, so there's an elective subject that some of the students have elected to take, and it is that conversation. It's the art of medicine, not the science, that is really difficult to teach. And so we're often talking about picking up that stuff in the room, that, who's feeling different, whatever. But my fundamental basis of that is because no one can learn everybody else's culture. No one can learn whatever. It's like, this is how we're practicing medicine in Australia. This is best practice model, but the thing that you ask is permission. We do have a thing that we talk to the students about, is the rule of threes. You have a third of your time on the, or thirds, it actually is the rule of thirds, third of your time you look at the patient's face. A third of the time you're looking at what you're doing, and a third of the time you might be looking off to the side. Now, when you're doing your speculum examination, the rule of thirds doesn't work, but you are checking in the whole time like this. And so you'll know, you glance up, you see what their face is doing, you go back to what you're doing. But when you're examining, say, a breast, you might look at their face, you will look at what you're doing, and then you will glance off. And we talk about that being the time when your brain is stopping all this stimulation and just getting the information from the hand, from what you're actually examining. So we talk about those sorts of techniques, but the important one is always checking in with your patient. One of the other funny things that we have to teach the students is, because we're taught constantly not to look at women's breasts, don't. So they will do the examination, they'll be getting the patient to do their arm movements and whatever, and they're still looking at the patient directly in the eye. You're like, have you examined the breast? And they're like, well, they've got them to do all this, but they haven't actually examined it. So the CTAs pick up on all that sort of stuff. I think the main thing is that the consent needs to be understood, and so that's where the teach back stuff comes. And if someone, they also get taught, if you go through your whole consent, then someone asks a question, you have to respond to the question, you have to reconsent. You have to reconnect understanding. So the consent is the very last thing. And I think it's just all about asking permission and trying to gain understanding.
Yeah, communication.
And communication between different cultural groups, as in the doctor being a different one to the patient, or it does take time. And that's really, what we're trying to teach them, is that best practice and working out ways of picking up those, what is going on in the room and how the patient is feeling, and checking in all the time with the patient.
Yeah.
Does that sound?
Yeah, that's part of my the question that I was looking for.
Yeah, from a cultural perspective of the doctors, we do get that. We'll have some of the doctors, some of the medical students be going, why do I need to do this? I'm going to become an ophthalmologist. It's like, well, before you're an ophthalmologist, you'll do a lot of other things. And as a doctor, you're responsible, you're doing a medical degree, not an ophthalmology degree, and you've got to be responsible to do this. And I always talk to the students about communication skills are super important. And if you can communicate well on what other people classify as awkward topics like sexual health, if you can communicate on those, the eyeball will be a cinch. So, that's sort of the thing that we do talk about as well, because that awkwardness doesn't just necessarily, it's not just a cross-cultural thing, it's an everything thing, unfortunately, here. Yeah.
And quite often people working in regional Victoria, they have to wear multiple hats at the same time. So even if this is not in their portfolio, they'll end up having to do this because of the course.
Yeah, and if we could have more people who even weren't doing the examinations being able to explain to people what they are and why we do them, and that's, which was one of the things that I didn't talk about, is why we've drop so much of the PAP testing, but that's because PAP testing is not the main reason that everybody has a speculum examination in this day and age. Now that, well, from the 1st of July, we can all have self-collected tests or clinician-collected tests without a speculum for cervical screening, and also cervical screening is only every 5 years. So, the number of times that people will be doing a speculum examination for that reason is proportionally much less.
Do you reckon this change in legislation would be a part of the upcoming curriculum for the sensitive examination? People getting to understand that it could be a self-collected specimen, so they'll have to change their instructions a little bit? Well,
we don't talk about cervical screening anymore. They used to talk about cervical screening, and they had all the brushes and all that sort of stuff out. We don't talk about that anymore. I've wiped it. So I sort of say, when they, what they say is, once you've got the speculum in and you've sighted the cervix, this would be the time that you would take your samples if you were taking samples. But there are other reasons to do a speculum examination. You might literally want to just inspect inside the vagina. You might be you know, suspicious of a sexually transmitted infection. There might be some bleeding. You might be doing it because, you know, you're looking to see whether the strings of the IUD are there. You might be looking to see if there's any bleeding, you know, if there's any products of pregnancy stuck in the cervical canal, blah, 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 blah. There's a gazillion reasons, but the CTAs don't teach those, but we just sort of say there's lots of different reasons. Yeah, I think that's the easiest way to say that.
All I can say is I wish I had that examination growing up, and getting to learn before actually being thrown in the deep end.
Yeah,
but
I think everybody does. And the medical students are really appreciative of it. They understand that. And the great thing is that they understand consent and policies for consent under anaesthesia, for consent other places are starting to change and be developed across all of the hospitals and clinical schools. It sort of makes you gasp that there aren't those kind of policies already. But one of the things is the medical students who have done this program, which is now 20 years, will be moving right through and becoming consultants, and therefore, you know, we will be able to change some of those policies. And even like the thing that amazes me a lot is a lot of the students aren't able to practice their exams because people say, oh no, you can't do a breast examination on a patient. But, you know, if you've got a patient who's happy to have a breast examination because a lot of patients really want to help students learn because they understand the longevity of that. And if you've got a patient that's in there for their ingrown toenails, they're bored out of their brain, but they had a breast lump removed a few years ago, it's like, why wouldn't you ask them?
Yeah.
But I think, you know, in some of the hospitals, that's a controversial thing. And I think it will be good when we have more of the doctors teaching the students who've already done this program and are encouraging them to appropriately approach patients and communicate with them and consent them and do practice their exams.
Pass it down the generations.
That's right. Yeah.
Well, thank you so much, Siobhan, for taking the time out of your busy schedule to talk to our attendees.
No problem.
I just wanted to reiterate that the video of this session will be available on our website, not on our YouTube. And if you have any other questions for Siobhan, please feel free to send them through to CERSH admin email, and we'll try to answer them for you. And thank you so much for today.
Great. Thank you.